Well, it is 8 a.m., so we will go ahead and get started. Good morning, everyone, and welcome to the September ABIN webinar. We are so glad you're here with us this morning. We have a wonderful speaker today, Dr. Dee Bernard. But before I introduce Dr. Dee Bernard, I just want to take care of a couple of housekeeping issues. We would like to ask that you keep yourself on mute. If you do have a question today, if you could put those questions in the chat box, and we will be monitoring the chat and we will be stopping and asking those questions. We'll also have a few minutes at the end for questions. I do want to remind everyone this is a recorded training. So by staying on the training today, you're giving us your permission to be recorded, and these webinars are uploaded to our website. With that, I'm going to go ahead and introduce Dr. Dee Bernard. We have Dr. Dee Bernard with us this morning, who is originally from Baltimore, Maryland. Dr. Dee Bernard came to ERISA Health by way of Tulane University in New Orleans, where he completed his medical degree in 2011 and his combined internal medicine and psychiatry residency in 2016. He graduated from the University of Virginia in 2000, earning his Bachelor's of Science in Chemical Engineering. His time between undergraduate and medical school was spent consulting in the engineering and IT sectors. As a physician who is dual board certified in both internal medicine and psychiatry, Dr. Dee Bernard guides the medical services team to provide optimized patient care and better enable ERISA Health to fulfill our mission to lead with exceptional care that nurtures the health and well-being for all. Dr. Dee Bernard feels driven to treat the whole person, both the mind and the body. He has interest in mood, illness, psychosis, and recovery services. And you can find him mountain biking and gravel riding when he's not otherwise engaged with his family or work. So we are so glad to have you here. And without further ado, I will turn it over to you, Dr. Dee Bernard.
Thank you so much, Kim. I appreciate the introduction, and thanks for Jenny's help also. And I'm really glad to be here today to talk about CCBHC and ERISA Health. So let me go ahead and share my screen. Let's see. Okay. It looks like I've got everything right here. So can everybody see a slide?
Yes.
And awesome. So let's go ahead and get started. I was invited to talk about CCBHCs, and Jenny, when she emailed me, used a language that I hadn't heard before, and it was, she said, hey, this sounds like reverse behavioral health integration, which it kind of is the opposite of what this group normally does, which is a primary care facility or some type of FQHC or general healthcare clinic that adds in behavioral health to, integrate behavioral health. And I guess that's the standard direction of medical care, adding behavioral health. A CCBHC, in essence, is a behavioral health agency that adds in primary care. So today I want to cover a few things. I'm going to talk about ERISA Health just because we're somewhat new here in town, and our newness was a little bit, people were distracted by the pandemic that's been happening these last couple of years. And then I'll walk through the community mental health center concept to make sure everybody understands that. And then I will talk about the CCBHC concept. And then I'll talk about opportunities for Arkansas DHS to embrace CCBHCs moving forward. So first off, ERISA Health is a 501c3 nonprofit. It is in the sole member model, which is a little bit confusing, and you can Google that and see how that works. But essentially, ERISA Health is the sole member of a group with 4 affiliates. These are Counseling Associates, Mid-South Health Systems, Professional Counseling Associates, and Ozark Guidance. And these 4 agencies are community mental health centers. And together, we serve 66,000 clients, provide over 800,000 services each year, and we have about 1,000 associates. And we provide a whole host of services, and now I'll highlight that we also have on-site primary care in 3 of our locations in Jonesboro, Springdale, and Conway, and we have a mobile unit that can orbit the greater Conway area. So what is a community mental health center? I had to understand that where the M and the B were in CCBHC and CMHC, and mental health and behavioral health are used interchangeably, just with different acronyms. And so let's first talk about the community mental health center. These are community-based care agencies that replaced hospitals from the past. Society as a whole over time has not been terribly kind to people with mental illness. Back in the olden days, people were just kind of stoned if they talked to the spirits or had challenges. Then people were put in asylums in the 1800s and prisons. Then that moved to inpatient psychiatric hospitals in the early part of the 20th century. And then there was a great change started by President Kennedy that led to the deinstitutionalization of persons with mental health. Folks had been purposefully moved out of these traumatic inpatient facilities and brought out to the community, and the funding was supposed to follow the clients as they moved out into the community and into these least restrictive environments. And it worked in one part because hospitals got a lot smaller. Total inpatient numbers shrank 82% from 1955 to 1988. And over time, the community mental health centers were able to bill Medicare and Medicaid for their services, which was great. And because these services are designed for people with mental health concerns who also have inadequate resources to pay for these services. So let's talk about Arkansas and see where these community mental health centers are. Each of these 12 agencies has a contract with the state to provide a set of core services. This regional numbering scheme makes my engineering head hurt a little bit, but it is what it is. And there are 12 agencies, and these agencies all have long and storied histories. I know that Ozark Guidance has been in existence for at least 50 years, and many of the other agencies have similarly long tenures and have been just mission driven to be dedicated to the people of Arkansas. And so since I got a map up, let's take a look at where ERISA Health is. ERISA Health is a combination of, again, those 4 agencies, Region 2, 7, 8, and 9. And together, this covers 41 of the 75 counties of Arkansas. We thought it was pretty great to move to an economy of scale because that's where healthcare is heading. And you know, we've had some challenges with that, especially because of that pandemic that occurred. The public health emergency declaration occurred 12 days after we became ERISA Health. And so that has been challenging to start a merger with 4 companies and end up with 5 and do it all in the middle of a pandemic. So we've been busy. The target populations of community mental health centers are individuals with serious mental illness and children with serious emotional disturbance. These are the definitions if you're not familiar with it, but basically it's somebody that has a diagnosable mental health condition, and that mental health condition significantly impacts their ability to do general life tasks, from you know, interfering with ADLs in very severe cases to just making work or participation in the community or getting your kids to school or being in school if you're a child. The mental illness can make those so problematic that you need an extra level of care. And so this set of population, the serious mental illness and children with serious emotional disturbances, are the bread and butter community mental health target population. What kind of challenges does this population have? Well, looking at adults, only 25% of adults with serious mental illness are competitively employed. And with competitive employment comes access to good employer healthcare coverage. It comes resources to provide for food, housing, and leisure. And if you don't have competitive employment, it's harder to make the ends meet. It's harder to get care because of the types of insurances that you might have. Adults with serious mental illness die earlier from all causes except for cancer than matched individuals who have the same health conditions but no serious mental illness. Sadly, the reason that folks with serious mental illness die less often of cancer is because they die so much earlier of other illnesses that they don't have time to get cancer. That stat made me really sad. Antipsychotic medications, these are wonderful and powerful and beneficial medications, but they come with significant harms like weight gain that can cause diabetes, that can cause heart disease, that can cause death. And so these medicines require significant monitoring and come with big costs. Adults with SMI use tobacco disproportionately more than those without. And with all of that deinstitutionalization and a lack of funding to meet those folks where they were in the non-institutional world, people with serious mental illness end up in these expensive places like emergency rooms, hospitals, and jails. Arkansas has recognized this and created the PASS system to address individuals with intellectual disabilities and other disabilities, as well as specific behavioral health populations, because these are the high utilizers in Arkansas. Let's go ahead and look at how many folks with serious mental illness there might be in our communities. The 2020 census put the Arkansas population at about 3 million, and of those, 76% are adults, or 2.3 million. And this is a slide from NAMI. It's a little bit small, I'll zoom in, but the takeaway, all of these numbers are the 12-month prevalence of these health conditions, which means at any one time in the last 12 months, this proportion of individuals would have met criteria for serious mental illness. I put that next to what we classically know as a bell curve or a normal distribution, where there's an average value, and then each of these bars is a standard deviation away from that normal. And so you see we're talking percentages of 1%, 3%, 4% of people who have certain mental health conditions at any one time in a year. And so these are what we call outliers, or groups that are more than 2 standard deviations away from what we call normal. So to zoom in a little bit and give you some numbers, at any one time in the last 12 months, 23,000 adults met criteria for schizophrenia in Arkansas. Almost 69,000 met criteria for bipolar disorder, and over 90,000 Arkansans met criteria for post-traumatic stress disorder that caused them to have problems meeting the duties of work, school, or home. And if we're looking at anxiety disorders, for over 400,000 people would meet criteria for an anxiety disorder based on these percentages from NAMI and the population in Arkansas. These are the people that seek care at the community mental health center. So let's move to CCBHCs. Let's talk about those. A CCBHC is a specially designated clinic that receives flexible funding to expand the scope of mental and substance abuse services available in the community. And CCBHCs provide care for people with unmet needs, and they cannot turn anyone away due to an inability to pay. Currently, there are lots of them. I'll talk about what the breakdown looks like in a couple of slides, but first I want to say CCBHCs deliver 9 core services. The first 4 services are bread and butter community mental health services. These include crisis services, screening, assessment, and diagnosis, as well as person and family-centered treatment planning, and outpatient mental health and substance use disorder services. So think like medication management and counseling services. In the CCBHC program, the CCBHC itself, that agency has to do items 1 through 4, but they can do items 5 through 9, psychiatric rehab services, peer support, case management, primary care screening and monitoring, and this intensive community-based mental health service for veterans. The CCBHC can do those things, but they're not required. They can align with what's called a designated collaborating organization, and basically you can team up with a service provider. And so when Ozark Guidance did its grant for a CCBHC project, the VA was one of our collaborating organizations because they provide a lot of care for veterans. We had the community clinic in Springdale, and they were one of our providers for primary care referrals until we had our primary care set up in-house. And really it's that core service number 8, the primary care screening and monitoring, that opens the door for the creation of an in-house primary care program. Because, you know, if you're going out and you're doing waist circumference measurements, you're calculating BMIs, you're talking about smoking cessation, it leads to an easy conversation to say, let me help you with that. Let's start some metformin for that diabetes, and let's start some varenicline for smoking cessation. So where are these facilities? Well, right now, as of August of 2021, they're almost everywhere in the US, but not all of them are created equal. I'm going to zoom out on this picture and add some words, and I'll say there are 3 types of programs. There are the demonstration states. These were the original 8 states that were selected in a competitive bid process. And on my picture, that includes Oregon, Nevada, Oklahoma, Missouri, Pennsylvania, New York, and New Jersey. And then they were selected as demonstration states in 2017. And in 2020, the CARES Act increased that to add Michigan and Kentucky. And so 10 states got full state and full SAMHSA involvement in their CCBHC project. And they had a cost-based reimbursement model that covered the full cost of care. And if the estimate of care cost was off, the rate was rebalanced in subsequent years to more closely align the rate with cost. Next, there's a group of expansion grant states. SAMHSA created a series of awards of $2 million a year, and those would go for, there would be a year 1 and a year 2 of this $2 million grant. And these grants were awarded over different competitive bid cycles in fiscal year 21 or fiscal year 20, 21, and 22. And these grants did not involve state Medicaid programs at all. Lastly, there is a group of 3 states, Illinois, Texas, and Kansas, where they had an independent state administration where the state Medicaid plan looked out across the landscape and said, this is such a good idea. We don't need the feds to help us with this. We're just going to do it because it's such a good idea. It's worth noting that 2 of those 3 states, Illinois and Texas, had planning grants, where this was in 2015. SAMHSA awarded over 20 planning grants to let states prepare for all the legwork it took to create the bid to be a demonstration state. Illinois and Texas had that initial grant, but did not win the demonstration state grant, but they went ahead with their programs anyway. So what does it mean to be a demonstration state? Well, the biggest thing is there are 2 prospective payment models that provide cost-based reimbursement rates. And really, when you're providing care to folks with serious mental illness, they have a lot of needs that don't fit a fee-for-service model. And the way to supplement that is to provide a rate through the state Medicaid plan that covers the costs of providing care to Medicaid recipients and to anyone else that may come to the clinic, whether they're insured or they have no funding stream. There were what they call them demonstration years, DY1 and DY2. The original demonstration year 1 rate was an estimate, and based on the actual costs, the demonstration year 2 rates were revised up or down based on cost. And these rates varied from state to state, and within each state, they varied among the clinics that provided care. So the first rate type PPS1 was a daily rate. So if you saw a person in your clinic 5 times in a month, you would get 5 daily rate payments in that month for the services that you might have provided. Those could be a crisis management service, a medication-assisted treatment visit, a treatment planning, a care coordination, and a primary care visit. There was an optional quality bonus program. And then in the payment model number 2, it was a similar type of arrangement, except you were paid monthly. And so if you provided 1 service, 5 services, or 20 services in that month to a Medicaid recipient, you got 1 rate. And these rates were paid either for a standard group of people, or there were 4 sub-special populations that included adults with SMI, children with SED, and adults and kids with substance use disorders. And then it was kind of hard to figure out how often you needed to see somebody in a month. So there was a relief valve that included an outlier payment for reimbursement costs if the cost wildly exceeded what the rate was offering. And in the PPS Model 2, a quality bonus program was required. And the quality bonus program measures included these 6 required measures and 5 optional measures. And so, you know, as you think about value-based care plans, some of the community mental health centers are in talks with the insurers about value-based care. Some of the other providers in the area are. And one of the awesomest things is there was a single list of quality bonus payment measures. And rather than having each different provider or payer come with their list of 6 things. And you know, if you get 10 lists of 6 things, you got at least 30 things to do because there's not a lot of overlap. So having a consistent set of targets was good. So I want to move to focus on our 2 neighboring states, Missouri and Oklahoma, because they took different approaches to how their CCBHC project worked. Missouri chose the PPS Model 1, that the daily rate. There were 15 CCBHCs in Missouri that opted into this. They were split pretty evenly across population distributions from urban to rural to frontier. All were nonprofits. 4 of them were also FQHCs, or the federally qualified health center that gets a similar type of bundled rate from the government for care to Medicaid recipients. And all 15 of them were health homes. So they either likely they directly provided physical care or had an arrangement with a designated collaborating organization. And because of this robust network of clinics that already did a lot of stuff before they became CCBHCs, they didn't really have terribly many designated collaborating organizations. And so let's look at their rates. So again, the rates varied among each clinic, and they ranged from $176 to $268 per day that a service was provided to a Medicaid recipient. And the average was about $224. And you see that this is the year 1 rate. This is the revised year 2 rate. And my takeaway from this is there was really almost no change that was appreciable in these rates. And so the Missouri CCBHCs did an excellent job estimating their costs. And they kept to that cost model. And this might be because they had such a strong FQHC knowledge base to start with 4 different FQHCs in this CCBHC pool. And quality is always a big focus, and the Missouri groups nailed it. Again, probably because of their FQHC focus on quality, but 15 out of 15 CCBHCs received a quality bonus payment, and that totaled $17 million across these 15 CCBHCs in just the first year. This is from one of the reports to Congress, and they do make a note that says initially Missouri had budgeted to pay 1% of total Medicaid payments as a bonus, and for some reason that went up to 5%, and they didn't know why, and I wasn't able to find the answer either. But ultimately, every CCBHC that was participating in Missouri got a quality bonus payment. And so what did Missouri say about this program that seemed to be kind of costly? Well, they loved it. This is the impact statement that was produced that was produced in Missouri to describe their program. These are great colors. These are great graphics. They increased patient access to care. The number of Missourians served by CCBHCs rose from about 110,000 to 140,000 by year 3. And this was a 2-year program that extended out onward past year 2. Almost 3,000 veterans were served. And this is the most important number, I think, here, which is there was a significant reduction in the use of ERs and inpatient psychiatric hospitalizations. That is where the cost is in state Medicaid. In Arkansas, that's $750 a day or more. And to be able to reduce costs in this range in these emergency services is awesome. Law enforcement loved it, and everybody hit their numbers. So we have these great graphs. The slides will be up so you can see them later, but Missouri did a great job. So let's talk about Oklahoma. Oklahoma was a different animal. They chose the monthly payment model, and they had some interesting approaches. They had one CCBHC in each type of region: urban, rural, and frontier. And so each of these clinics was sort of facing the unknown all on their own, because they had different criteria and sets of, how do you go out and care for folks in a big frontier rural area versus an urban area? All of them were nonprofits. None of them were FQHCs, but they all were health homes, and 2 used designated collaborating organizations. And so let's talk about their rates. It's pretty confusing, this table that I have here. It's busy, but let's break it down. So there's a row for each clinic on the left, and then there's an average for the cost. In the prospective payment model 2, there is a division among populations, and those special populations get different rates. So there's the standard population rate, which is just folks that aren't in the other groups. Then there's adults with serious mental illness. There's kids with serious emotional disturbance, adults with significant substance use disorder, and then Oklahoma chose to add one group that was folks that are chronically homeless or first episode of psychosis at all ages. You'll notice there's no 4, and that's because group 4, which was a SAMHSA defined group, was children with or adolescents with significant substance use disorders, and they just didn't have enough clients on each of the 3 clinics to report that. But you can see that the average cost of caring for the standard population was resulted in about a $700 a month payment. And in some of these special populations, the costs increased to be significantly higher. It came up to be an average of $1,200 a month to care for homeless clients, or adults with SMI, or kids with SED. And so that was the approach. And again, the Oklahoma, using this model, was required to pay a quality bonus payment. Again, they had the same measures, which was very helpful. And Oklahoma didn't do so well on the quality bonus payments, and because they didn't meet the threshold. Why? Well, I would guess from this is Oklahoma had a hard time in the first year really getting this sorted, because each clinic was in a different location and served such a different range of folks. And the fact that there were significant changes in the reimbursement rate from year 1 to year 2 said that they had a less well done cost estimate. And so I think there were just some challenges there. But Oklahoma picked itself up, dusted itself off, and said, we're doubling down on CCBHC, because Oklahoma expanded their CCBHC program with a state plan amendment. This is the cover of the Certified Community Behavioral Health Clinic Medicaid manual. And I'll just give a shout out to these guys, because it's only 36 pages long in contrast to some of our Medicaid manuals. And it has some snazzy graphics. But as of 2021, there are now 8 CCBHCs in Oklahoma, and they have continued on in the prospective payment model number 2, where if you become a new CCBHC in Oklahoma, you get your standard population rate gets $562 if they come in for at least one service in a month. And if you're serving one of these most in need clients, adults get an additional payment on top of that $562 of $775, and kids get an extra $508. So Oklahoma is doubling down on this in a big way. They don't publish year 2 rates because, again, those fluctuate based on the cost of year 1 and the prior year. So that's how they more closely align costs with incentives. And Oklahoma had, they didn't publish an impact statement. They went ahead and just loaded the impact statement for all CCBHCs from the National Council to their website. And I put these, I lifted these quotes out of that report to just show you that Missouri loved it, Oklahoma loved it twice, Texas, which was an independently administered state, loved it, and Michigan was one of the new expanded demonstration states. They loved it also. There were some additional quotes. You'll see that this one is from Burrell Behavioral Health in Missouri. They love CCBHC. And that's interesting because Burrell recently pulled out of the Arkansas market because of the reimbursement rate not matching costs. And so Burrell flourishes in Missouri, did not flourish in Arkansas. Main difference there is Arkansas is not a CCBHC state that pays the cost-based rate through the Medicaid program. So let's talk about Arkansas. Arkansas is an expansion grant state. That means that the state Medicaid plan is not involved in the CCBHC administration or payment, but 7 of our 12 community mental health centers won competitively awarded grants directly from SAMHSA. That totals $27 million, and that's even more than I thought it was. And I had to go look at the SAMHSA website and look at all the different fiscal year awards to piece that together, but it's almost $27.5 million. And each of these grants is up to $2 million a year. And all 7 CMHCs were awarded grants for both years, year 1 and year 2. And this money had some strings attached to it. It limited the amount that could reimburse direct services, but it did cover labor costs, which was a significant cost driver for all of the CCBHC programs. And this is what allowed us to really dip our toe in the water of primary care and hire primary care staff as we try to navigate the creation of a primary care program inside of our community mental health program. So we're grateful for the support. But let's look at where these grants are. We've got Western Arkansas Counseling and Guidance in the West. We've got Ouachita Behavioral Health in Central Arkansas. We've got South Arkansas Regional Health Center in South Arkansas. We've got Centers for Youth and Family in Pulaski County. And then we've got ERISA Health, 3 of its 4 affiliates won these expansion grants. Professional Counseling Associates here did not, but these other 3 did have the grants. And so with these grants, they supplement fee-for-service revenue, and they give us the flexibility to go out and try to add things like ACT teams or do care coordination for our clients. As I said earlier, these clients have had challenges where they may not be competitively employed, or they may not have insurance or housing challenges. And so some of these folks are slippery fish, and it's hard to catch up with them. And so let's look at a couple places where Arkansas Medicaid missed some opportunities that could have been covered in a different way through a CCBHC project or at some type of cost-based reimbursement. And then we'll look at current opportunities facing Arkansas Medicaid as we move forward, where there are opportunities to act and change things to be a rising tide for all Arkansans. So one missed opportunity is the Crisis Stabilization Unit pilot program. This is one of those quotes from previously in the CCBHC manual, or the CCBHC impact statement from the National Council. And Oklahoma is saying that its 24/7 crisis unit decreased the need for psychiatric inpatient hospitalization by 93%. That's a huge amount, especially given the cost of care in those types of facilities. Again, at least $750 a day at the Medicaid rate. The CSU pilot program was exactly that kind of program, and it was an awesome program, and it was done incredibly well. And Ozark Guidance and Mid-South were thankful to be parts of this program because there were 4 sites. The state covered 2 years of funding to cover the complete cost of the unit, which was awesome. But the funding ended at the door, and there were some quirks in where the facilities could be in a given location because the monies for the pilot program did not allow for construction of a facility, and the Field of Dreams mentality just didn't quite extend out to the CSU program, which is if you build it, they will come. The Sebastian County CSU was within visible distance from the emergency room in Fort Smith, the main one that's there. So a hospital staff member could say, we called the crisis stabilization unit. It's right there across the highway. It's not that building. It's not that building. It's between those two. You go right through there and they'll leave the light on for you and they know you're coming. And so they could be full, especially during the pandemic. The Pulaski County Crisis Stabilization Unit was down in the middle of Little Rock, and so everything is accessible on foot there. The Washington County facility was near the center of Fayetteville, but that was very distant from all of our jails and very distant from most all of our hospital emergency rooms. And just through quirks of EMTALA and transportation funding, there was no explicit funding to transport clients that met criteria for the crisis stabilization unit from hospitals or jails to get them directly to the CSU when they needed it. And so it was hard to get out of the fur-lined rut that led right to an inpatient psychiatric hospital. And if there was a cost-based funding model, the CMHCs that provided care in Washington and Craighead counties could have pivoted and said, we have an unmet need, let's cover the cost to get people here. And that would have more easily allowed us to have clients in the bed and have a full facility day in and day out. So let's talk about some other opportunities here. Arkansas Medicaid passed on an opportunity to bid for a planning grant and a demonstration state grant. And when the states won the expansion grants and we wanted to integrate primary care, we realized that there was a policy decision from Arkansas DHS prohibiting co-location of primary care providers inside community mental health centers. We actually had to go find a friend in the state legislature, which was Representative Lee Johnson, who sponsored a bill to explicitly authorize the co-location of non-behavioral healthcare services inside outpatient behavioral healthcare agencies. This was House Bill 1682, and it became law by Act 760 last year in April 19th of 2021. And this is what opened the door to allow us to have primary care clinicians inside community mental health centers. This was a big lift. The next challenge we had is Arkansas opted for the PASS system instead of a CCBHC cost-based model. And so the PASS system is specifically for clients who have an intellectual disability or other disability waiver already, or they're on the waiver wait list and they get Medicaid state plan services, or folks who live in developmental disability intermediate care facilities, or clients who have behavioral health diagnoses that need additional services beyond medication management and counseling. And there's a third-party screening company that examines every client that is offered to this higher level of care with behavioral health diagnoses to make sure that they meet criteria to access these services. And so this is a lot of overhead and cost that does not go directly to patient care. And these the passes are like managed care companies, and we negotiate rates with them, which is nice, but the negotiated rates are still based on the outpatient behavioral health service fee schedule, which is not really reflective of the cost of care. So I don't want to dwell in the past. So let's talk about opportunities for adoption and change as we move forward. So we've got an available opportunity here today now. And currently the OBHS Medicaid manual and fee schedule are in the process of being updated and partially retired. Care at the community mental health center is governed by this manual, and these rates are dated and they have not kept pace with inflation. And if anybody's been reading the news or been alive and shown up at work in the last 2 years, the only thing that's happened to the cost of care is that it has gone up. We are currently in talks internally to raise our minimum wage because we are just having a hard time competing with Target. The Fayetteville School District is paying bus drivers $19.30 an hour to drive a school bus, and that's sometimes better than answering the phone for us for $14 an hour. And so, so these rates can be revised while this manual is up to be changed. This third-party independent assessment requirement can be sunset. In the pandemic, it was almost impossible for these face-to-face assessments to occur, so the tiered ratings just persisted, and which meant that they weren't terribly needed. And when we send people for an independent assessment, more than 90% of them achieved some higher tier status, tier 2 or tier 3, indicating that we were doing a pretty good job of only sending the people that we thought met criteria for a higher level of service. And I think all of the CMHCs have had similar performance levels. And so the money that's being spent on third-party independent assessments by Arkansas could be spent somewhere else. That's an opportunity. Another opportunity is the Community Support System Provider Manual is currently in development. The rates for this are not yet set in stone. And this is a perfect program to adopt the prospective payment model type number 2 that could target specific target populations with cost-based rates and required quality targets. And so the same groups that are eligible for the pass could be the specific target populations, and each of these target populations can have a different cost-based rate associated with them that really that would let Arkansas target care providers to address specific groups individually and to get the best bang for the buck. So this is an opportunity that's available today. Let's look at how how care is currently provided in under the Medicaid manuals. And so this is an excerpt from the primary care physician manual and the physician manual of Medicaid. They're actually almost the same manuals, and they're found at the Arkansas DHS page here. And this is the section on psychotherapy, and it's pretty old. It's from October 13th of 2003, so almost 20 years old. And I'm going to highlight a section of text here. Me being an internist, I'm a dual boarded internist and psychiatrist, and if I have my own shingle, I can do psychotherapy as a psychiatrist, and I can bill the physician Medicaid fee schedule. But if I work under the community mental health center roof instead of my own shingle, I can't bill that rate. I have to do a different thing, and that's a policy decision that is in the Medicaid manual. And what does that mean at the end of the day? It means that our mental health professionals are currently, we're struggling to pay folks enough to compete with private practices, because the discount that if I as a physician do psychotherapy, or if our mental health professionals who do psychotherapy, we're stuck billing the OBHS rate, and that requires that I take a 44% pay cut just because I'm providing psychotherapy under a different roof. And if I do a 60-minute session, if I'm under my own shingle, I can get $166. And if I do it under the community mental health center roof, I only get $92. And again, that's a 44% reduction. If I, being an internist and a psychiatrist, if I want to do medication management and psychotherapy, if I'm under my own shingle, I can do that and bill for that. If I'm at the community mental health center, they don't have a billing code for that that's accessible. And so I have to purposefully underbill that by billing an E&M code for medication management and psychotherapy. And so for a level 4 visit, I would lose out on 27% of the revenue that I do there. To look at the additional fee schedules, they're different sizes. A physician fee schedule in Arkansas Medicaid is 477 pages. So I guess physicians can do a lot of stuff under their own shingles or in hospitals. Nurse practitioners can do a whole lot, but less than physicians. And the community mental health center gets 2 pages. So we can't do very much here. But one of the opportunities that's available is we could decrease ER and hospital visits by reversing a policy decision and allowing physicians at community mental health centers to bill level 5 visits. The recent changes from CMS in how care is billed in E&M codes made it much easier and straightforward to bill based on medical decision making, and the complexity of the clients with serious mental illness and serious emotional disturbance just lend itself to mainly being level 4s. And the passes are currently asking in their value-based contracts to be able to request visits in an attempt to stave off or delay inpatient psychiatric hospitalization, but we can't bill for that because our base fee scale is limited to the OBHS billing structure, and we have to underbill to be a level 4 when we do a level 5 visit. And that means I have to miss out on 40% of the revenue that I might get as a physician. Then my nurse practitioners would miss out on 46% of their revenue because of the way that the OBHS fee schedule is designed. Again, this could be changed very quickly, as early as tomorrow, to help provide a better cost-based plan that would allow us to provide the type of care that's needed to reduce hospitalizations, and it would allow us to have better access to a mental health professional pool of labor, because we would be able to have more sustainable cost base or rates that are closer to our costs. So let's talk about takeaways. Arkansas has immediate opportunities at hand where they could adopt some of these CCBHC program benefits. 7 of the 12 community mental health centers are already CCBHCs. And so a majority of CMHCs are already hungry for a state plan amendment that could allow us to adopt a cost-based rate plan to provide all of these awesome services that are active in the CSSP manual, or that are coming up in the CSSP manual. 12 out of 12 community mental health centers are facing significant workforce challenges. Immediately changing the Medicaid fee model to allow community mental health centers to bill not in the OBHS fee schedule, but in the regular Medicaid physician or even the nurse practitioner fee schedule would allow, would take a bite out of that workforce challenge with mental health professionals, physicians, and nurse practitioners. And that's one of the first steps that Arkansas could take to align revenue with the cost of care, which is ever increasing. And lastly, the CSSP rates are not yet set in stone. And this is a perfect model to apply the prospective payment system, where we could target specific groups with cost-based reimbursement that can decrease the total healthcare spend that includes budgeted revenue and emergency services that are always unbudgeted. And that would ensure access to willing providers who are incentivized to provide quality and sustainable care. And another immediate opportunity for Arkansas Medicaid is the ability to be a leader and impose consistent quality measures for the passes. like I said, our revenue structure is based mostly on the OBHS fee schedule because 71% of our clients are Medicaid associated, either with traditional Medicaid or in the PASS program. And in order to manage the 28 different quality measures that our agency is required to attend to, either by accrediting agencies, the various passes or various guidelines, I have to now build a data management team and a data management infrastructure. And we have all of these workforce challenges and rate issues. And so Arkansas Medicaid could be a leader and say, these CCBHC quality measures, these main 6, these are the required measures for all the passes. And otherwise, they could add in any other measure they wanted. But this is an opportunity for Arkansas Medicaid to lead. We hope they take it. And, I believe the CCBHC program has all kinds of good features that our state Medicaid plan could adopt. So those are my takeaways, and I'll leave it now for any questions. Thank you.
That was a great presentation and looking at what the other states are doing too. So thank you. It was good information to kind of help guide us, I think.
Thank you.
Thank you, Dr. DeBernard. We did have one question about the crisis stabilization unit.
Sure.
So the crisis stabilization unit is now open again in Fayetteville. And we just the question was, could you talk a little bit about the crisis stabilization unit, the model, and has the location changed? What do you think will have to be different this time for it to be successful?
Sure.
As launched?
Ozark Guidance exited the crisis stabilization unit contract in I think the summer of 21, give or take. And now UAMS has taken up the contract, and I am not sure of the details of that contract. But UAMS is providing service at the same location with the same bed size and including some of the same excellent team members, including the director, Kristen McAllister, who is an amazing advocate for all people who have gotten care there. Kristen is just wonderful, and she will continue to ensure that there is a wonderful level of service provision at the CSU. But I'll have to defer any kind of funding opportunities or challenges to UAMS and Arkansas Medicaid.
Be happy to answer any Medicaid questions that come up. So I'll be here if there's any questions.
Thank you, Paula. Did that answer the question for the person who is interested on the crisis stabilization unit?
It looks like there's a new question about the CSU and police referring to the unit. And actually, there were a number of police who would refer to the unit. And the challenge was actually getting the client who was in police custody to the crisis stabilization unit because we drew from Washington and Benton counties as well as Madison County. And for large departments that were just up the street, like Fayetteville was, blocks away, it was easy to transport clients over. For Washington County Jail, it was easy to transport clients over. But for small jails in Madison County, for Cave Springs Police Department, for other smaller outlying police departments, it was a pretty significant challenge to send one of their officers, which represented a significant amount of the patrolling police force at any given time because they're small. It was hard to transport clients and devote that officer's time to that task, taking them off of the law enforcement or the ability to respond to their community. And there were challenges with payments between counties for this type of infrastructure, and it led to some great compromises led by Sheriff Tim Helder, and so it was just a tremendous lift to get the clients there. And so a lot of law enforcement agencies chose to not use the crisis stabilization unit just because it was hard to get to. And through a quirk of how the EMTALA laws worked and the requirement that a client could not be actively suicidal in the CSU, in order to meet the not actively suicidal admission criteria, that ended the EMTALA covering emergency in the emergency room. So transportation that would be mandated to be arranged through EMTALA to get someone to the place that could provide care no longer applied. So the client who was eligible for the CSU had to walk there, had to get a cab there, had to pay out of pocket for some kind of transportation, or have family come to the emergency room to transport them. And oftentimes that was just not possible. And so we would have loved to have been able to have a cost-based reimbursement to provide transportation services, because that was what was needed for our physical location in Northwest Arkansas. And our additional location in Craighead County also suffered from that, just because of where the facility was located, kind of far on the outskirts of town across a significantly busy railroad crossing.
Thank you, Dr. DeBernard. Okay, we have another question. The comment is, could you speak a little bit about how primary care and behavioral health are working together to support the whole health of the client? And I'd also be interested, we did have Dr. Lori Rainey here last month, and she talked a little bit about outcome measures in that process. And so I know you showed quickly some measures that need to be met, but I wondered if you could speak to specifically, what are some of the measures that need to be met? What are some of the outcomes? And just this whole approach, this reverse model. I know we only have 4 minutes, so we're asking a lot. But so
the biggest deal is people with SMI and SED are slippery fish. They have a hard time fitting in waiting rooms. They have a hard time showing up for appointments on time. They have a hard time paying their bills at clinics. And so these folks filter down to the community mental health center. And this is where these clients have developed a level of comfort with the facility, with the provider, with our mission. And with all of these health challenges, we thought it was really excellent and easy to expand our care out from just the brain to encompass the entire body. And so what a great place to start to talk about smoking cessation at the community mental health center with a provider that you know, or a new provider that's a primary care provider that you might meet by being walked down the hallway to say, you know who I'd like you to meet? Let's go talk to Katie, our nurse practitioner. Let's go talk to Megan, our nurse practitioner, who can talk to you about some health concerns. And if you're showing up to get your long-acting injectable antipsychotic injection, then we can, measure your BMI. We can check an A1C and see how you're doing and say, hey, let's also talk to you about these measures. Because smoking cessation is one of the measures we have, assessing for hemoglobin A1C, assessing lipids, assessing waist circumference, just, the standard similar measures that are out there across all of the different types of like FQ clinics and primary care clinics.
Sure. I'm curious, are patients receptive to that? And are there any types of measures, for example, getting a baseline A1 and A1C and then follow up in 6 months or 12 months? Have we seen a decrease in A1Cs, and how's that working?
Too soon to tell. Our first primary care clinic patient was served in December of 2021. So, and we have just had a really hard time integrating primary care and growing that service. And so we're really working hard to get this off the ground, to get those numbers that would be able to show, benefit or lack thereof.
Kim, in some of the CCBHCs that started prior to us, they are showing some excellent outcomes across all the mandated measures. And we've got a group that's working to put that storyboard together for us. So the answer would be a resounding yes. In both nights in jail, utilization of inpatient has decreased. Many of those things Dr. DeBernard referenced, we are mirroring on those initial CCBHCs.
Wonderful. I can't wait to see the storyboard and look at the the outcomes. All right. It is 8:59, so I just need to ask, do we have any other burning questions or input? We've got some comments that this was a great presentation. Let's see, our patients are very receptive to our clinics. One part of it, this is the rapport built with the behavioral health providers. It helps carry over to the primary care team. I do have a question. Do you have additional people trained in a BHC type or a PCBH model that are working on the care team in the primary care clinics?
Tell me PCBH. What is that acronym?
That's the primary care behavioral health model.
Is that the model where there's the primary care physician or practitioner plus a mental health professional together?
Yes, so it's an embedded behavioral health specialist within the primary care team.
We have not opted yet for that model because the client group that we are initially targeting is our clients that already exist. And so everyone that's at the community mental health center already has a mental health diagnosis. And so we're able to utilize our mental health professionals that are behavioral health mental health professionals down the hall to bring them in for conversations. But as we expand our scope and our client base, adding in the primary care mental health professional to also see a client in tandem or in succession with the primary care provider is the move that we would make.
Awesome. I was just curious because there is some specialized training for that piece. So, okay. Well, thank you all for staying on with us today. I know everyone is busy and has meetings starting and clinics starting, so we appreciate your time. And please, if you have additional questions and you want to send them my way, I'll forward them to Dr. DeBernard and Arissa. And we are so grateful for you all here in our home state of Arkansas to talk about your experience with reverse integration and your successes with the current model that you have. So thank you again and have a wonderful day.
Thank you.